Hi, everybody. Welcome so much to our presentation on osteoporosis, fighting it with targeted exercise and nutrition. I am Dr. Kate Campbell. I'm a physical therapist for RVNAhealth. I treat patients as well as help manage our practice and its growth. I've been treating for over, 15, 18 years now, and not only in our beautiful facility downtown on Governor Street, but at the Golf Performance Center where I can really get people to lift heavy weights, run and jump, and do lots of exciting things. We have a great team here to talk about exercise and nutrition, only the best, of course. Monica Marcello is our registered dietitian. She's going to talk about nutrition, and another very wonderful experience at physical therapist, Andrea De Lange, will talk about your exercise program. Because this is so popular, we ran out of packets. So if you did not get a packet, there might be a few floating, and our team in the back can help, but the material will be emailed to you because we got your email on your sign-up form. I'm going to share a lot of information today. We're going to start with what is osteoporosis, but if there's anything up here that you think, oh, that pertains to me, I don't have a handout because it's a pretty lengthy presentation. I'm not proud. You can take pictures of it. You can jot notes down. So I'm more than happy to share my information with you. So who's here because you have osteoporosis? Okay, it's not everybody. Who's here because you have osteopenia? Okay, that's like the other little bit. Is there anyone who's like, I'm just worried and I want to know and I want to prevent this? Yes, thank you. We sent out an email today saying we're trying so hard to fight this and beat it, but honestly, prevention is the best thing. What would you tell your kids? What would you tell your grandkids? What would you have done differently? So I hope that by the end of this, as you'll see what we can do to help you in your disease process, those are the things that you can share to do to prevent it as well. Good to know. I have a lot of information that kind of builds, so let's hold questions till I'll let you know, but I do want you to feel free to talk and ask. I want to make sure that I'm presenting clearly. So we're going to talk about what is this disease, what are the risk factors, what can you do about it, are we going to do it with exercise, how are we going to do it with nutrition. So the formal definition is a systemic, whole body, skeletal bone disorder characterized by lone bone mass and microarchitectural deterioration of bone tissue, and it increases fragility and susceptible to fracture. Susceptible doesn't mean you have to, it could happen. And when you go to a physician to get diagnosed with osteoporosis, it is because you have a score of negative 2.5 or lower. Don't worry, we'll go through. All this means is the bones are not as strong as they should be. They're not as dense as they should be. They're a little thinner. They're losing instead of strengthening. This is kind of what it looks like. See, down to the cellular level, we can see that those fibers are just a little bit thinner, and they look a little bit more frail, and they're more susceptible to break here. Their bone has an outer shell, and then the inner shell is really the inner, those cancellous bone is what we call, is more susceptible. Yes, you have this diagnosis, but why do you care? Why is this important? It's because it affects so many people, 10 million people in the US, 8 million are women, only 2 are men. As we go on, you'll figure out why is it more with women than men. 50% of women, 25% of men will have a fracture in their lifetime. And following a hip fracture, 20% of patients will die in the first year, mostly due to pre-existing medical conditions. They already had chronic heart failure, they already had diabetes, and then they have this hip fracture, and then they don't move because of the hip fracture, and then it's harder, and then the sequela and the downward spiral. But that's a pretty scary statistic, and the hip does get fragile with osteoporosis, so we want to really strengthen those and prevent those fractures. Medicare, of course, cares greatly about this because it costs them $25 billion. And the biggest spots of the osteoporosis are forearm, humerus, hip, and spine fractures. and mostly in women. 61% of the fractures happen in women. And if you've had a fracture before, you were 86% more likely to have another fracture. Okay, it's scary, yes? Don't be scared. It's so scary. We're gonna try to empower you to say, no, I understand this is serious. I need you to take this seriously, but I want you to feel strong and in control. So I'm totally nerdy on all the science and what goes down at a cellular level. I'm gonna graze through it quickly just so that you can appreciate all the amazing things that are happening in your body normally. Bone is constantly changing. It says, oh, there's a little stress there, a little fracture. Let me take that out, clean it up, and then I'll put some more in. And it's constantly going through this cycle of take and give and take and give. Down at the cellular level, we have these osteoclasts that find these little fractures, and they're like little Pac-Men, and they come along and they eat the debris. And then because they did their job, it signals to the next cell to come in, and osteoblasts, B for build, osteoblasts build more, but it's not solidified. It takes months before that new bone becomes really mineralized and hardened. And it has to happen in the right environment. But that's down at the bone level. Then we have going on through our body all these hormones that affect. When you think calcium, we think bones and teeth. Is there calcium anywhere else in your body that's important? Totally. Our nerves are conducted with calcium and our heart. So they're really important. It shouldn't just be in our bones. So the body is always constantly taking a test. How much calcium's in the blood? How much is in the blood? And if there's too much, it'll say, oh, that's too much. I'll just put some in this bone here, and I'll store it away for here. And then if there's not enough in the blood, it'll say, okay, I'm going to take it from here and take it from here. And it's this constant dance of take and give based on hormones, and the hormones that are listening to that come from the thyroid. So there's a lot of osteoporosis connected with hypo or hyperthyroidism that we need to address too. Again, a lot of detail, you just need to understand that that's why part of the nutrition. So if we have a perfect environment, the perfect amount of calcium, the perfect amount of vitamin D to put the calcium in place, the right levels of estrogen, which is actually important, plus the stress that loads the bone, we have a beautiful normal bone cycle. Usually there's more going on early on in life. Our bones grow and grow and grow, and they peak between, this one says 30, but it was more like 20. That's it. We're all over that. It's all downhill from here. We hope not. We hope to stabilize that, but that's normal and it's okay. It's normal and it's okay. Osteoporosis is when it goes too low. Okay, so if I was telling my kids, you know, hey, you don't want to deal with this later, I want these numbers to be as high as possible so that if it does dip, it's not going to dip too low. Does that make sense? So now we know how bone is constantly changing and molding and assessing and fixing and growing and decreasing a little bit. In fact, it changes over so much that every 10 years, you have a new skeleton. 10 years. That's quite a lot of skeletons in our life, right? So if things are changing, fractures heal. Bone is a wonderful tissue to have injured to because it heals. It heals with bone. Osteoporosis just means it's more likely to break, and it might take a little longer to heal. But it shouldn't be scary. It shouldn't mean you have to change your life. Great, so you came because you have osteoporosis, and now we need to do something about it. Any questions about what I just went through? Yeah.
I do have one. There was a statement up there that said a prior fracture leaves you at increased risk. Does that mean a fracture when you were in your 20s or a fracture?
That's a great question. And that a prior fracture increases your risk of refracturing. It's an osteoporotic fracture. So no, the fact that I fell out of a tree and broke my elbow when I was 6 does not mean I'm more likely. That's a really good question. If you've already had an osteoporotic fracture, it means your body was already at that breaking point, and then it increases your likelihood. Yeah.
Is there a difference between a fracture that's caused by a car accident versus a fracture that's caused by just a trauma?
So, nope, a fracture is a breaking bone. A couple of years ago, my grandma at 89 called me and said, Katie, I can't come. I just fell. She was in line dancing class and she fell and she said, I'm in the ER, but don't worry. They think it's just a fracture, not a bone break. And I go, no, Grandma, that's the same thing. So a fracture is a fracture. It doesn't really matter. And the mechanism of injury is maybe more how we characterize a traumatic fracture, which would be both a vehicle accident or a fall because it's an injury. And an external force necessarily versus a compression fracture, which happens often in osteoporosis in the lumbar spine, way down here, these 5 bones down here, because of extra pressure. And we'll talk a little bit more about that too. So those we call compression fractures, which it's a little bit of too much force over time instead of a one too many. Does that make sense? And then compression fractures, stress fractures are similar, but not just from a compressive force. It might be from a torque force or a bend force, but it's just a little too much that builds up. Okay, so bone can withstand stress, and it needs stress. This is good. This is a segue into where I'm going anyway. It needs stress to grow, but there is a magic threshold, and it's invisible, and we don't know where it is. So with osteoporosis, we know that the threshold is less, okay? If it goes past the threshold, it breaks. You can do one big force and hit the threshold and break, or you can do little bits at a time and build up and overfill your glass and break. We need to figure out where is your threshold, and we need to stay under it, but we want the threshold to go up. We want to use exercise and a good healthy environment of calcium and vitamin D to make that threshold higher so it can withstand more and more forces so it's less likely to break. Does that make sense? So that's what we're going to learn how to do that. Okay, any more before I go? Yes?
Yeah. You've got 4 things up there: calcium, vitamin D, estrogen, and stress.
Yes.
I got all 3 except estrogen.
Okay.
So over 60, estrogen, maybe 0.
Correct.
So how do you get estrogen if you have osteoporosis? Over 60, but you didn't.
Right. We're going to talk to the doc. I can't fix that. I can't. This is life. This can happen earlier or later, depending on when menopause, depending on cancer, depending on your medical history. So yes, there is so much of that hormone needed, and because women go into menopause, that is why there is 3/4 of you are women here and not men. It is because of our drops in the estrogen level that makes us predisposed to having osteoporosis. Yeah.
But I was wondering about something, because I'm aware that doctors have stopped prescribing estrogen replacement therapy for some years now because there's a risk of cancer with it. Yet, perhaps it might be advisable in women who have osteoporosis, and I don't think they're doing that.
Yes. The question is, but if you need estrogen, then why aren't we getting estrogen? But then it leads to cancer, but then there's what if they need it? And that's the conversation to have with the doc. Our team and I went back and forth with what kind of information can I give to 90 people? Because I can't be perfect to every single person in this room. So I'm going to be as generalized and safe as possible. I don't want anyone going out there and doing like a 200-pound bench press and hurting themselves. Like, I want you to take away the concepts and yes, that's something to consider. And then when it comes to you, talk with the physician, meet with the team, and let's make a good plan, whether it's chemically or food or exercise-based.
So we don't necessarily need trauma to have a fracture, is what you're saying?
Correct. The magic word is stress, load. And load can be in little bits that build to hit that threshold of too much. It could be, all I did was bend over and pick up that pencil and I got a fracture. I sat and I plopped in the chair and I got a fracture. It wasn't that event. It was the fact that it was building. Or it could be a trauma. Obviously a fall would be much easier because it's such a high force, load, stress. Yes, exactly. Okay, so time to act. Let's go. We go to the doctor and they are going to test you talk to you about your risk factors, and please don't come away scared to move. I've seen this all too much. The doctors will always usually send for blood work, and they're looking for calcium, they're looking for vitamin D levels, but sometimes we have to ask them to also get a phosphorus level. They're going to look at the thyroid because the thyroid hormone has so much in regulating how much calcium goes into the bones and into the blood and vice versa. Again, the vitamin D level and a 24-hour urine calcium collection, which is a pain in the neck, but it's worth it. Next, they're going to do a DEXA scan. And this is a lie down, get scanned procedure where they're looking at bone mineral density. And they pick some spots on the body that are more susceptible to fracture, more susceptible to pressures, and they can compare you to age-related body norms to see if you are at risk and you get a certain score. So here's someone who's lumbar spine, and they're looking at their area, their bone mineral density, and their T-score. And here is a hip. Can you see it now? Kind of like right out here. And this is called the neck of the femur. The hip is actually this ball and socket joint, but what you feel out here is out here. And usually the neck is where it's predisposed to fracturing. So those are a couple. They'll do some other spots as well. If it is below -2.5, it is considered osteoporosis. If it is below -1 to -2.5, it is osteopenia. And no, if it's 0, that's great. That's fantastic. It's normal that it's going to go down as we age, as long as it doesn't go down too much. It's important for us as physical therapists who might take you through an exercise program to know your DEXA scans. Bring them in. Because if you have a 2.5 in one place on your body, you still have osteoporosis. But it's not that bad. It's only a little bit at one spot. Great, I'm going to change my exercise program to safely work on that spot, but I don't want to ignore it, and I'm going to give good stress to the rest of the body. I think if it was all -3s, then I might be a little bit more careful with you. We need this information. Just having osteoporosis doesn't mean I'm going to treat everybody exactly the same, because that threshold is the magic level, and we want to get as close to the threshold as possible. If we're too far, we're not doing any service. If we're too much, we're going to cause injury. Talking to the doctor about your risk factors. There are some things you just can't change. How old you are, I have no fountain of youth. Your mom had it, I can't change that. This is one of the things about being skinny all your life. You and gravity haven't met. So gravity hasn't been pushing on you all your life to cause bones to get denser. So those who have had a low body weight as you're growing up are more likely to have osteoporosis. If you never exercised when you were young, if you have some endocrine disorders, rheumatologic disorders, GI disorders, anything that causes inflammation in the body. And Monica's going to talk a lot about how inflammation and bone healing are not best friends. So anything like that could predispose you, and I don't know what you can do about it. But if you notice, I have these risk factors, maybe I have to be a little bit more on the prevention side. Maybe I have to work a little bit harder to make my environment for optimal bone health good and balanced. And then the estrogen deficient, obviously, if you have it younger, you're more predisposed to having osteoporosis later on. But here are the things we can do. If you don't move, start moving. If you are not exercising, start exercising. If you're not just careful about what you eat or focusing on the right food, get the right diet, and then hopefully your physician sends you to us to have a better conversation. If there's some medications predispose you to osteoporosis, antacids, proton pump inhibitors, SSRIs, heparin is blood thinning. Men that have prostate cancer might have some meds, and steroids all weaken bone. So, but like you were saying, that was a risk that the doctor had to take to fix whatever problem the medication was prescribed. uh-oh, we have this side effect, now you're osteoporotic. Where can we balance? Can we take away a medicine? Are you better? Can we change the type of drug to target the problem a different way? This is what the physician has to talk about, because you got it for a reason, but is the reason worth it? So they are changeable. And of course, alcohol and tobacco use, never good for those bones. Don't be scared. Osteoporosis is a scary word. You're not going to die. It's just your bones. Everything else is working really well. People walk away with, I can't touch my toes. If I bend over, I'm going to fracture my spine. But you got out of the car okay. And you tied your shoes. And yesterday you had osteoporosis too, and you didn't fracture yesterday. So whatever you are doing, load-wise, stress-wise, environment-wise, is keeping you here. We have to find more. The answer is not less. The answer is not, I'm going to be scared, I'm not going to do. Whatever you're doing is good. Now we have to slowly increase it. They say, don't fall, you better not fall. Well, yeah, I mean, no one should fall. So do something about that. Work on your balance. Make safe choices. It's going to snow. I hope we all get home before it gets icy outside. Come to our class about how to fall safely, how to dissipate those forces so that it doesn't land hard on your wrist and doesn't land hard on your back or your elbow. And don't stop exercising, because if you don't move, this will get even worse. So that's what you should talk to the doctor about, and then hopefully you say, great, thanks. Now I'm going to go meet my RVNAhealth team and talk about nutrition and exercise. Any questions on that? Yeah.
So when you say doctor, are you talking about endocrinologists, rheumatologists, gynecologists?
Great question. So PCP is a great, primary care physician is a great place to start, because they should be your team lead and know all about you. They should know which doctors you are seeing, what you're seeing for, and they should be the one that communicates, well, I'm glad you got this med from this guy, but this one, they shouldn't go together. Usually the gynecologist is the one that says, oh, it's time, let's get you through the DEXA scan, and starts that process. But if there are predisposing factors because of endocrine, then the endocrinologist, I think this is a team decision. So whoever starts it, then you bring it up with each of the other physicians and keep that conversation going. In a perfect world, we hope that they're all talking. Anything else? Yes.
Let's say you have osteoporosis and you do all of these things for a couple years, and now you go for your DEXA bone scan again. And let's say it's in your hip or your spine. Is it possible to instead now have osteopenia instead of osteoporosis?
That is a wonderful question. I love it. Does anyone know the answer? If you have a diagnosed osteoporosis and you do everything right, can you turn it into osteopenia? Or let's go a step further. If you have osteopenia, can you get rid of it and turn it into normal bone? Yes? Raise your hands.
Yes.
No, you're stuck with it. Raise your hands. Most people don't know. I'm so happy you're here. Thank God you're here. It's reversible. Bone heals. Bone grows. But you got to work really hard at giving it the right environment. And if we work together to give it the right environment, it can change. Your T-score can change. Bone heals in normal bone is 6 weeks. An osteoporotic fracture might be a few more. That's okay. You have a new skeleton every 10 years. Let's make the next skeleton even stronger. But we've seen T-scores change. And the study that we're going to talk about, they took older adults with mega osteoporosis. In fact, they found the lower scores got even better. And the study was 8 months. So how about that? Less than a year. Statistical change in 8 months. Yes, let's do this. Okay, environment number 1, the right nutrition. So Monica, come on up.
Hi everybody, and thank you so much for being here. My name is Monica Marcello, and I am the RVNAhealth Registered Dietitian Nutritionist. And I particularly specialize in osteoporosis and digestive health. And I sort of say I do anti-inflammatory solutions to all things bone health and gut health. And you'll see that there's quite a bit of overlap. I do one-on-one private counseling, and I also do interactive cooking classes We also have one this Friday on osteoporosis recipes. We have like 3 to 4 more spots available if you're interested in that. I'll talk a little bit more about that after. So before I move on, I want you all to take like a deep breath, because we're going to share so much information, and I don't want you to feel like you need to run home and do all of these things all at once, because things can get lost in translation. So I would so much rather you just be open and receptive to this information than feeling like you need to do everything all at once. I'm glad it's empowering, but it's more effective if you can just take a step back and really understand the concepts first. So with that, my first question is, can I have a show of hands for people who have been following some sort of osteoporosis diet or anything of the sort? Yes. And where did you, well, I guess let me ask that. So show of hands, where did you get that information from? Was it a doctor? 1 person. 2 people. Was it a dietitian? 1, 2, 3 people. Was it the internet or social media? Yeah, okay, there's more people, I know it. And so that's why, again, I'm so happy you're here, because that is so common. And I'm really here to talk about those ideas and concepts and hopefully provide clarification, because the devil is in the details. So with that, I want to start with what I've sort of come up with as the osteoporosis nutrition hierarchy. And it's this idea that you cannot just be supplementing with vitamin K2, if those of you who are familiar with what that is, we will dive into it, and have a really poor diet. That vitamin K2 is going to be so inefficient in your body if you are not starting from the ground up. And so that's also important to know, is that doing things one at a time is going to be more beneficial than doing things. Can you hear me better like that?
Yes.
Okay, thank you. Doing is going to be more beneficial than doing things all at once. So again, the osteoporosis nutrition hierarchy looks like this. Starts with the very foundation, which is an anti-inflammatory Mediterranean diet. I'll talk about getting tons of vitamins and minerals in, because when you eat a diet that's diverse in all these whole foods, plant foods, you're getting so much of your nutrition in through your foods, which is going to be the best way, and we'll talk more details about that later. Okay, so again, that's a lot. I usually do presentations, to be honest with you, just on the Mediterranean diet alone, and now I'm just condensing it into this slide. So again, that's why I just keep encouraging you. It's so hard to learn all at once, never mind in 3 to 4 minutes. So just try to keep thinking about the concepts. So the second thing, right, so after we sort of establish that foundation, we eat more whole foods, we eat more fruits and vegetables, we're getting our proteins from beans and nuts, as well as oily fish. We really want to think about, how are we getting in our protein? So protein is sort of a controversial area, as are most things with food and bone health, as are most things in general with nutrition, to be honest. But protein was once thought, and I would love to see a show of hands if anyone had heard this. Protein was once thought too much protein was bad for the bones. Did anyone hear this? Some people nodding. But did anyone also hear that too little protein is also bad for the bones? Yes, and both are true. So where does that leave us, right? And that's why I really emphasize moderate protein intake, because too little, we need the muscles to support the bones. Not to mention that proteins, the sort of building blocks of proteins, also go directly to the bones as well. So there's part of the food that you eat. Protein doesn't just go to your muscles. The amino acids, which are those building blocks of the protein, also supports your bone. So we need enough protein. We also want to make sure that we're supplementing our exercise with protein. And obviously we know how important that is, or we will know by the end of this presentation, how important that is for osteoporosis. So my recommendation is it's individualized. I can't sit here and say, everyone have a minimum of 80 grams per day. That wouldn't be accurate. So usually there is a certain, I tend to do in practice, I individualize the protein, and it's a very moderate amount to support muscle growth and decrease bone mineral density changes. But the most important thing, believe it or not, is spreading your protein out throughout the day. How many of you, and honesty is key, because I used to do this too, feel like you eat the majority of your protein at night or in one meal. Yeah, yeah. And that's, again, Western culture. That is so common. We think about our dinner is the biggest, most important meal of the day. Well, guess what? You're actually really decreasing the amount of muscle that can grow when you only have protein at one meal a day. And this is shown again in time and time again in research that the body actually stimulates more muscle growth and more growth when you spread your protein out throughout the day. So what does that look like? I'll give you an example. If you have if I say, hey, I did your calculations, you probably want about 80 grams of protein per day. We wanted, now I made myself do math, hold on, 20, 40, 60, 80, okay, great. So we want to have about 4 meals per day that have about 20 grams of protein each. And that is so, so important. And now you'll also see that I sort of talked about, or I wanted to highlight rather, the most important forms of protein as it relates to not only osteoporosis, but things, again, this is a reoccurring theme, that are found in the Mediterranean diet. Tempeh, has anyone heard of tempeh? Has anyone tried it? So we've heard of it, but we haven't really tried it. I see some people like, no, I have. Tempeh is actually going to be one of the proteins that we are highlighting in our cooking class this Friday. But I love tempeh. Again, it's more plant-based. Same thing with tofu. Tofu, actually, surprisingly. How many people, show of hands, eat tofu regularly? Yeah? Now, keep your hand up if that's because you are on a plant-based diet or way of eating. Not many. It's just we sort of like tofu. That's great. That's awesome. Tofu, actually, has calcium in it as well. Of course, I highlighted the salmon and the tuna as amazing sources of protein. And that is, again, they're part of the Mediterranean diet and that they're very anti-inflammatory. And also just a great source of high-quality protein. Also, got to talk about our dairy sources, right? Yogurt, milk, also great sources of protein. And then we have sardines. Okay, I'm nervous. Show of hands who eats sardines. No way. Okay, that's impressive. That's amazing. So, superfoods don't really exist. Sorry to break that news to you. I'm doing a cooking class on that later in this year. They don't really exist. But if there was a superfood, sardines would be one of them. Why? Because they have vitamin D, high quality protein, they are affordable, and they taste great. And they also are very high in omega-3 fatty acids, which again is that real anti-inflammatory property in these fatty fish. Yes?
I have a question about tuna, the mercury in it, about salmon, wild or farmed, and about yogurt and milk, the fat content. Could you address those?
Yes, I love that. Details. The devil is in the details. Okay, tuna and salmon. So there's minimal research to support eating salmon 2 to 3 times per week is going to be toxic in terms of the mercury content. The research is just not there to support that at this time. And so for me, the benefits of consuming tuna, again, affordable, portable, and very nutritious, outweigh any of the risks associated. Salmon, this is a tricky one, I get this a lot. So interestingly enough, farm-raised salmon has actually higher omega-3 content, which is like that true anti-inflammatory property of the food. But some people just prefer wild-caught because the idea is that it's a little bit more sustainable. There's really not a great answer to this. I actually you're not the first person to ask me this, and I'm sorry that my answer is a little underwhelming, but it's honest. And in terms of the sustainability or the health, both have risks and both have benefits. So if I think, people tend to feel good about wild caught, and that's totally fine too, but if farm raised is more affordable and more in your budget, please feel good about that as well. That's what I do, so. Now milk, this is milk and dairy, you ask. Okay, this is a tricky one. And this one really goes down to individualizing it, but I will say, if I have to generalize it, which I am now, 2 things. One, people tend to shy away from full-fat dairy because of the amount of fat. And a lot of people with like cardiovascular, heart disease, high cholesterol think that full-fat dairy is going to be bad for them. Well, there's research that really shows the opposite. Even though it has some of the fat that's maybe like not the best, they actually find that the fat in dairy can be more cardioprotective. And so seniors A lot of times, especially in the context of osteoporosis, because I will be honest, the fat doesn't really matter so much for the context of osteoporosis, and maybe I should have led with that. But when you think about the big picture, you understand that people who are seniors tend to be a little bit more thin. They've lost weight. And so usually, I actually recommend 2% or more to help people maintain their weight or even increase their weight, because we know that that's beneficial for osteoporosis and maintaining bone mineral density. Does that answer your question? Beautiful. Yes. And
Where are eggs on this?
great, eat them. They're a great source of protein. As you can see, it's a little tight for slides. Yes. Cheese, also a totally appropriate source of protein, but when I think about protein, I like to categorize it as high source of protein, moderate source of protein, and low source of protein. So like low, think about like your peanut butter, and again, think about this all in the context of osteoporosis, right? These are gonna be the highest sources of protein that are also great for osteoporosis. When you ask about cheese, even though it has calcium, right? It's still sort of a moderate source of protein, meaning that it takes, sometimes you have to eat a little bit more to get the amount of calcium. So it's not always the case, but I, again, consider that more moderate. Okay. And I just want to say, if you can write down your questions, that would be amazing. I do want to answer all of them, but I just want to be mindful of the time, and I could talk forever, so you don't want that. All right. So I promise, please write down your questions. I'll be happy to answer them either as a group, or please catch me after the presentation and I'll speak with you one-on-one. Okay, so after we've mastered that sort of anti-inflammatory eating, we're eating our fruits and veggies, we're eating more salmon, sardines, we're also getting our protein at every single meal. Calcium, right? Where does calcium fit in? So I want to take a step back before we talk about dietary calcium to think about what calcium actually means as a mineral, okay? And so, believe it or not, calcium is the most abundant mineral in the body. Kate even mentioned this, so it plays a bigger role than just in your bones, though I will admit it is 98 to 99% found in your bones. Stored in your bones. And again, levels drop at the start of menopause as a result of decreased estrogen production. Another note is that calcium, and this is a common area of confusion, but calcium measured in your blood, right? So if you go ahead and get your basic blood work from your doctor and you see your calcium is high or low, that's actually not necessarily indicative of your calcium intake. That's more, if you have high or low calcium in your blood, that's actually more alerting the doctor that you probably have something off with your thyroid. So that's what sort of makes this like a big, like scary world. Like it's hard for us to know, are we actually getting enough calcium? Because we can't. Unlike vitamin D, right? We go get our vitamin D tested. Well, that's a little bit more accurate of how much vitamin D we are consuming, but not necessarily for calcium. And so again, Kate mentioned this, but the best way to measure, your calcium is by a DEXA scan of the bone or the urinary calcium as well. And so generally speaking, and the numbers that I work off of is about women over the age of 50 need about 1,200 milligrams of calcium per day. And so this sort of goes back, I just want to further reiterate, so we understand why we need the calcium, right? Because if calcium levels are balanced in our blood, the bone is not going to feel the need, like it has an emotion, but the bone is not going to take the calcium from the bone and put it in our blood. Because the blood is going to be like, no, we're good. We have enough. And the bones can keep the calcium for themselves. So that's why calcium is so important. Okay, so, did I skip a slide here? No. All right, so, again, what do calcium and Goldilocks have in common? Low calcium is bad, more calcium isn't better. 1,200 milligrams, again, if you're over the age of 50 and you're a woman, 1,200 milligrams is just right. So, low calcium isn't good because you're probably not getting your blood and your bones enough calcium to have, to maintain. And more calcium, you're actually at a modest, I will emphasize the word modest, risk of cardiovascular events and kidney problems. How many of you, show of hands, have heard of that calcium supplement? Something, okay. Yeah, so I do not want to scare you, but what I do want to do is emphasize the importance of hitting that 1,200 milligrams. And this also means food and supplements, right? So between food and supplements, you want to be at 1,200 milligrams. And I also want to emphasize again, because the point of this presentation is to educate and empower, not to scare, that it's a very modest risk of high calcium intake and the cardiovascular disease events. Okay, so it's low, but it's there, and that's why we want to just make sure we're educating people. So calcium type and timing. So calcium is actually best absorbed in the body in smaller doses. So similarly to protein, you want to spread out your calcium intake throughout the day. My recommendations, and I also should make sure it's important for me to say, the best calcium you can get is through your food. I'll say that again for people who love to buy supplements. The best calcium you can get is through your food. Now, it's always okay to supplement your food with calcium if necessary, okay? So for people who are on a plant-based diet or this is just too challenging, then we can talk about what a calcium supplement looks like for you. But again, calcium is best absorbed in smaller doses between 300 milligrams and 400 milligrams. So if you're doing the quick math, that means you want to have about 300 milligrams of calcium 4 times a day, or 400 milligrams of calcium 3 times a day. Now, what does that look like? What does 300 milligrams or 400 milligrams look like? Well, it's hard to know exactly. You know, dairy, like I said, is going to be your best source of calcium. And good news, it's also a great source of protein. So you're sort of killing 2 birds in 1 stone. That's usually why I really love to recommend it. Throwing out quick examples, some yogurts. Now, I feel it's important to know that not all yogurt brands or not all yogurts, 5 ounces of calcium Chobani looks totally different than the Chobani and Faye or Okios or whatever. So make sure you are reading the label. But generally speaking, you can find about 250 to 300 milligrams in like a glass of milk, your fortified soy milks, 5 ounces of yogurt. Those are like general recommendations that I have. So of course, other sources for my plant-based folks out there, tofu, as I mentioned earlier, molasses, you can put that in your smoothies, sesame seeds, collard greens, of course, fortified foods, and white beans. So I want to show you, for example, my schedule, my calcium type and timing schedule. So I do the 300 milligrams 4 times a day, and this is what it actually looks like in real life. It's sometimes really hard to take all these numbers and all this jargon and then make like, well, what do I actually eat? So here's an example for you. So breakfast, you can have oatmeal, and I always cook my oatmeal with 1 glass of milk. My preference, now I will say it is a little bit more expensive, but is Fairlife milk. It does have higher calcium and higher protein. So again, it pairs really nicely with the oats to give me a high protein meal. Other sources are, of course, your regular milk, or if you're plant-based, making sure you're finding a plant-based milk that has calcium in it as well. Then for lunch, as part of my lunch, I'll do a yogurt with fruit and chia seeds. Chia seeds are high in fiber, so again, we're fueling that gut. All part of the Mediterranean diet approach. Chia seeds are actually high in calcium as well. So if my yogurt's like 200, I put a few tablespoons of the chia seeds. It pairs really nicely to give me about 300 milligrams of my calcium. Now, I'm not perfect, right? And it's hard for me to get my calcium in at all times. So I have a 300 milligram supplement of calcium around my snack. Now, depending on the supplement that you're taking, you can eat it with food or maybe you cannot. It depends on the type of calcium. And then dinner, I'm going to have 1 ounce of cheese with my dinner. So that's an example of how you can actually make this come to life. Moving on. So, and again, questions, happy to answer them, and I will totally at the end. Vitamin D and calcium. How many people are on vitamin D? If you're comfortable raising your hand, you don't have to. Lots of people. Okay, here's a better question. How many people were recommended vitamin D from their doctor? Wow, good amount. Yeah, we live in New England. We're not getting it from the sun. I am too. It's tough for us. But then this is just interesting to know. So vitamin D, actually, just nod the head. Does anyone know why we have vitamin D? Like, why is this part of the osteoporosis diet or regimen? Do you know why? Helps absorb calcium. Helps absorb calcium, absolutely. Also, I'm going to throw in another interesting point there as well, that it helps with inflammation. So there's more and more research that keeping your vitamin D, not just, so I don't know if you know, so it's like 20 or lower is deficient, but 20 to 30 is like insufficient, they call it. So generally speaking, we want our blood levels to be 30 or more, and having that closer to 50 when you get your blood work done is actually more indicative of people who are less resilient to stress, colds, things like that. And so there's now more information suggesting that vitamin D actually plays a very significant role in overall anti-inflammation. But I should tell you what the research says regardless, and that is that generally, we find that people who take vitamin D have the greatest benefit of taking vitamin D if their vitamin D is less than 30. We do find, and honestly, I'm sure, like mine was less than 30, mine was almost 19, which is crazy. Also, I should say this as well, that if you have gut problems, your vitamin D is also more likely to be low because you're not absorbing it. But again, the research shows that if it's less than 30 and you're taking vitamin D, you're going to have a greater benefit. Like the supplement can actually do more. But once you're over 30, it's going to have a very modest benefit. But nevertheless, it's still an important part of the osteoporosis diet. Now, again, it's not absolutely necessary. And very rarely are we over-consuming or over-supplementing with vitamin D, although it can happen. So my recommendation is that if your doctor told you to get it, then you should continue on. But if you're not so sure, get your levels checked, because this taking vitamin D usually is not going to make or break your sort of osteoporosis outlook. So just be mindful about that. Okay. All right, now we're getting into vitamin K2 and bone health. Has anybody heard about vitamin K2 for osteoporosis? Let me guess, the internet? No? No, where'd you hear about it? Oh, that makes sense, okay. So, there's a lot of information on vitamin K2 and bone health. And so we know that vitamin K1, which is found in our dark leafy greens, is really important for overall health, right? That's what we're most familiar with. And that's, again, like I said, found in your leafy greens, and if you're eating that Mediterranean-based diet, you're, again, probably getting these nutrients in. Vitamin K2, on the other hand, has actually, again, been shown to work on the cellular level of the bone, and it's been shown to stop or decrease bone resorption, and also increase those cells that help build up bone as well. Now, it's so important to note, though, that vitamin K2, there's a certain level of vitamin K2 that will actually do this. What is that? And I use this example, right? When you say you're hungry and you eat like one cracker, you're not full, right? That's because one cracker is never going to satisfy anyone. But if you eat a whole meal, well, you're going to be full. The same sort of thinking applies, right? If you just take like, oh, now the supplement had vitamin K2, this looked good, that may not really do much, because there's a certain level that's called the clinically significant level that's been shown in the research to actually work on the bone on the cellular level. And research has shown time and time again that people who are taking vitamin K2, and I'll tell you the amounts, don't worry, but they're right there, but people who are taking the vitamin K2 in addition with calcium and in addition to a bone healthy diet or lifestyle have improved bone mineral density. So again, talking about the reversibility of osteoporosis, so they're showing that people who have osteoporosis in some areas actually have improved, like I said, bone mineral density, osteopenia, and reduced risk of fractures. So even with vitamin K2, there's another level. There's different types of it. There's an MK4, which is most abundant, again, in animal foods, but not necessarily the foods that sort of fit in on a more Mediterranean diet approach. And so I don't usually, and plus it's important to note that amount of this MK4 that you get in your diet, you'll never get enough of it in your diet to reach that clinically significant point, the point where it's actually affecting, having a positive effect on your bones. Similarly with MK7. Now, MK7, again, they both act a little bit differently on the bones, but are important to take. You could either take one or both or the other, and that's where I definitely recommend meeting with a dietitian to discuss this. But MK7 is actually found in NATO. Does anyone know what that is? No. Okay, so it's a very commonly eaten food in Japan, and that's where actually a lot of this research came from on the idea of vitamin K2, MK7. It's a fermented bean. It would probably look pretty different for us, but it's a fermented soybean, and it produces vitamin K2, MK7 in a clinically significant dose. But if you're not eating that, and let's be honest, most of us are probably not, again, you want to take that, or you can consider, you can consider and meet with a professional about taking it via supplementation. So the recommended, those clinically significant doses, and by the way, that's a piece of information you can take with you through everything. Think about your supplement regimen. And it's so good to meet with somebody to think about, is this a clinically significant dose? Is this really worth my money? And is this having the health benefit that it is saying that it's having, or I'm thinking it's having? But so the recommended dose for vitamin K1 is 90 nanograms. For vitamin K2, MK4 is 45 milligrams. And then K2, MK7 is 180, that's micrograms, 180 micrograms. And last, actually one more slide, is selenium. So selenium is an antioxidant that's been shown to be very important for bone health. Again, in traditional Western diets, it's unlikely that we're meeting the recommended dietary allowance, which is 55 micrograms a day. And again, there's also research that shows that selenium works on the cellular level of the bone and also has anti-inflammatory, antioxidant pathways in the body as well. And so I just like to say, if you can eat one Brazil nut a day, you're good. Osteoporosis nutrition prescription. What does this look like? So I would recommend Mediterranean diet, lifestyle, way of eating at its core. Follow up with protein at every single meal if you want to meet with a dietitian who can help you identify what does moderate protein intake look like for me. One 300 milligram supplement per day in the morning, and then 300 milligrams calcium servings of low-fat dairy. Again, this is for me. This can be mixed and matched in any way that feels right for you. This is just an example, right? And you can really see here how we're doing the 1,200 milligrams of calcium from food and supplement with an emphasis on food. One Brazil nut, 5 to 6 prunes per day. And then, if you want to be really bold, 1 tablespoon of NATO, or potentially having a vitamin K2 supplement. And then, of course, vitamin D if needed. Now, the last thing I just want to touch on before we talk about exercise is anti-nutrients. Has anybody heard, well, I should put quotes, anti-nutrients. Has anybody heard about anti-nutrients in bone health? Yes. Does anybody purposely avoid these foods? Okay. Well, I want to tell you why you shouldn't. So, first of all, vitamin A has been shown to be an anti-nutrient if you're consuming way too much of it, which most likely people are not. Look at your multivitamins. That's my only recommendation. It's cheap, it's easy to put in multivitamins, and I bet a lot of them have way over the recommended dose. So if you are, maybe it's time to look at your multivitamins, see how much is in there, and find a new multivitamin. But other than that, you don't need to limit the foods that have vitamin A in them. Sodium. This gets people really concerned as well. And the research shows that unless you're consuming a ton of sodium, like well over 2,300 milligrams, which is the recommended amount per day, you're probably fine. Caffeine. You're gonna really, really like me after I say this one. So, caffeine has been shown in the media, the internet, to be this like the worst thing for calcium absorption. Guess what? 200 milligrams of caffeine only decreases calcium absorption by 6 milligrams. So, you want to have your coffee? Put 2 tablespoons of milk in. Boom, you're done. You want to have 2 coffees? Same thing. Add a little bit of milk to make up for the calcium loss. That's it. And then, of course, phytates and oxalates. So, these are foods that are known as anti-nutrients that are, they're plant components found in foods that are known as anti-nutrients. They're found in whole grains, they're found in leafy green vegetables. Ironically, they're found in a lot of the foods I just told you you should be eating more of. And that's because the research to support that phytates and oxalates found in food, and if that actually interferes with calcium absorption, is just not there. There's actually research to suggest that people who eat more of these phytate-containing foods, more spinach, more collard greens, more leafy greens, more whole grains, have decreased risk for fractures and improved bone mineral density. And the reason for that, again, going back to the beginning, is likely because of following a Mediterranean diet, and those are foods that are made up of, or really emphasized in the Mediterranean diet. So thank you for listening. Thank you for being so attentive. I know it's a lot of information. Take a deep breath and please enjoy Andrea as she talks about targeted exercise.
Wow, that was awesome. Thank you so much, Monica. I love that. I learned so much. Hi, I'm Andrea De Lange. I'm a physical therapist at the RVNAhealth, and I work with Kate Campbell, and I work as a physical therapist in the clinic a couple days a week. But another thing that I also do is I teach wellness classes on Tuesdays and Thursdays. 1-hour classes, and one class in particular called Strength and Beyond is kind of geared towards osteoporosis. So that's what I'm going to talk about today. So we're on the exercise portion that we're going to talk about. So is everybody tired of sitting? Can we all just stand up and stretch? This is a lot of information, and we need to get moving. Everybody's stretching. Yeah, that feels so much better to get moving. So I want to talk about exercise, but with osteoporosis, as we've all learned, there are, for certain things, there's specific nutrition you should do. As Kate described, the process of, or the things about osteoporosis, there's also specific exercise that we can do. And we know that we need to, as you've heard over and over, is this stress bones, building more bone, and that kind of thing. And that's because of this factor called Wolff's Law, which, being a little bit nerdy like Kate, we have big bones and we have small bones, right? We have big bones because basically the more stress that we apply to a bone, the bone will actually adapt. So as we were kind of talking about this presentation, Kate and I were talking about, so obviously we're going to talk about impact, what type of exercise, progressive lifting, all those kinds of things. But we're also stressing muscle, which is attached to the bone, which then stresses the bone. So that's Wolff's Law. Did you guys get that? I don't want to be like overly repetitive. Okay, good. So you guys got that. Okay, so some exercises are better than others, right? And so we have, I'm going to talk about these 5 areas that we need to do when we exercise. So one is specificity. So we talked about how we have these big bones, we have small bones. So bigger bones that get more stress are like our hip, right? Our lumbar spine, those bones are bigger. And so if I'm somebody who has low bone density in my spine, I'm not going to get that by taking weight and going like this, doing my bicep. That's not going to strengthen my back, right? So they have to be specific. So I'm just going to demonstrate this by things that we can do that are specific and that apply to daily life. Do I just hit?
Hit the space bar.
The space bar. All right, here we go. And you can see this woman here. It looks a little scary. She's got some big weights, but you can see how it's really applicable to regular life. We all have to do these things, and you can see where impact loading, we're bending, we're jumping, we're doing a burpee, we're doing all these things in life, and we don't even really know it, right? And look, she's smiling too. Look at that. Right, so, secondly, these exercises need to be progressive. So what do I mean by progressive? Meaning, they should feel heavy, right? Weights should feel heavy and they shouldn't be the same. If you've been lifting, if you've been in an exercise program with a trainer who doesn't know a lot about osteoporosis and things like that, and you've been doing the same weight and the same program over and over, maybe those T-scores aren't changing, and that's probably why, because they need to be progressive. As Kate mentioned, having osteoporosis, this condition, or osteopenia, this condition is reversible. So it's not, something that you can't change, and you can't go to normal per se, but you can get better. And also, another good important point is that we tend to think like, if you're one of those people who are like those really low T-scores, you're osteoporotic, believe it or not, the people that had the lower values are actually, their bones are more sensitive to stress. So those are the people that are going to see the bigger gains, which is kind of going towards the myth that, oh, if I lift a weight, or I should just sit and do exercises in a chair, and I shouldn't do anything because I'm really at risk. But if that's you, that's the person who should be doing this program, because you're the one who's going to respond the best, okay? And the final thing I just want to mention is diminished return. And what I mean about that is kind of a little bit to what Monica was saying, is if you're someone who's here, which I saw a whole bunch of hands go up, who said, I'm just here for prevention, right? So you're the person who's going to go and you're going to look, you've learned everything you learned today, and you're going to do all the right things, and you're not going to see a lot of change. And you know why? Because you don't need to. And the other thing is, those of you that have done this program and you're doing all the things that you're learning today, and you're progressing and you're doing all the right things, you're going to eventually plateau. So don't get discouraged and too caught up in the actual values. But the important part is, if you stop just because you get there, you could get worse. So you want to be mindful of that. So what are the type of exercises that I should be doing, right? So here are the 3 types of exercises. We're going to give you all the answers today, people. Progressive resisted, so we talked about that, right? The weights that you should be lifting, they should be heavy, they should feel heavy. I don't mean like too heavy. We keep, the theme today, I think when you guys leave here, should be the Goldilocks of everything. The Goldilocks of stress, the Goldilocks of...
Calcium.
Thank you, calcium. Right? And so the same thing with the Goldilocks of, you don't want to do too much, that you get injured, too little, that you're underdosing yourself, and that you're not going to change. So with that said, I want to just show you guys, here is progressive loading. It might just be a picture.
No, it's different.
Okay, there we go. So notice, they're lifting overhead. There's another point here I'm going to make. They're velocity driven. Some of them are jumping, which is an impact. We got some men in there. We got the women in there. And that's progressive loading, and resisted training. Then we have high velocity. So we want, as you saw some of those people lifting overhead, we can increase our bone mineral density if part of it is velocity driven, meaning we have somewhere in there, an increased speed or explosive, fast, like, for those of you, I don't know if you guys know these terms, but like a snatch or a clean, and I'm going to show you some of these, or a plyometric, which would be like a jumping event where your feet actually leave the floor. Okay. So here we go. This is a snatch. See how it gets faster, like he's zipping his sweater up over his head. And we have a couple others, and he's doing a little jump. He's not actually leaving the floor. Or a heel drop, which we're going to talk about certain exercises in a second. It's not just the men, the women are there too, and they're doing a great job. And then the third thing is weight bearing and impact training. So examples of that would be a jump, right? A heel drop. So, you know, like a heel drop where they have to make a sound, or, right, like you can't just, a lot of people say when they're, well, I do weight-bearing activity when I'm exercising, I'm walking, that's a weight-bearing activity. But if you're somebody who went and got a DEXA scan and you are in that osteopenia, osteoporotic range, and you're doing walking and your T-scores are not changing, then you're not doing enough. And so here is an example of what each activity in this left column and what the ground reaction force is. So what that means is what you put into the ground. The ground, in, you know, everything has an equal and opposite direct. Any of you nerds, you know, you physics nerds out there, right? Equal opposite reaction. And so what you put into the ground comes back up into your bone. That impact builds bone mineral density. So a lunge, right? A lunge, right? Or walking is only 1.2 times your body weight. So if you're somebody whose T-scores are not changing and you're walking, you are not doing enough. You need to come down the list here and get higher. Now, for those of you who are not doing a program who are saying, well, I can't do that. I can't do a vertical jump squat. That's insane. Well, that's true. So what is great about going to, and you don't know what you should be doing, that's what's great about RVNA Health, is that we are trained professionals to come to your level and get you up to the right level. So in other words, I wouldn't have somebody starting off who never really exercised or did any impact training. I would start with, you know, beginner exercises, which I have another slide for that, and build you up to the point where you're doing enough ground reaction force to mitigate and get your scores to where they need to be. All right, everybody got that? Everybody good with that slide? Okay.
What is a vertical squat jump?
A vertical squat jump. You guys are making me do it in heels, right? Did you hear it? Did you hear it? Okay. So here's an example of impact training. So right now, this wonderful woman is doing like what you would call a overhead lift. That's impact training. Now look, she doesn't look like your typical CrossFitter, right? Oh, styrofoam. No, it's not. She doesn't look like a typical CrossFitter, right? Somebody, you know, big and buff, and she doesn't look like somebody, you know, in the TV commercials and all that, but she's doing it, and she's doing a great job, and it doesn't always have to look pretty. Which, you know, not everybody who exercises can look like that. So these are other types of weight-bearing exercises, because as we know, the wrist and the forearm are also important areas of osteoporosis that can be problem areas. And these are what we call inchworms or bear crawls and things like that. Some of you might be saying like, I can't get down on the floor. That's okay, we have an exercise for that. So don't even worry about it. There we go. Wait, is there another one? Okay. Did we just do this one?
You just did that one. Did that one.
Did we get it? Oh no, the next one. Here we go. No. Oh, I'm going backwards. That's the problem. Okay, sorry, people. There it is. There we go. That's one. So here we go. Impact training, right? So she's hitting the floor, ground reaction force, plyometric. She's not totally coming off the floor, but she's doing pretty good job. Okay, yeah, I have to hit the right button now. Sorry about that. Okay. So, you don't believe me? Do you believe me that what I'm telling you is true? All right, so the research is coming around. I don't want to I want to tell you these things without saying that. I can back it up with some scientific research. And the research is shifting, and there are more and more studies like this. This is called the Lift More study. Get it? Lift More? Okay. And basically what they did was they looked at, oh, I went too far. Okay. What they did basically is they looked at 49 postmenopausal women over the age of 65 for 5 years. And they had one group of the women did 4 exercises. One was a deadlift, one was like a chin-up jump, but what they did was they jumped over the chin-up bar like this, but then it was the dropping impact that counted. They did an overhead lift, and did I say 4? No, there was. Oh, and I think they did a heel drop, and they did a heel drop, which is just, you heard that, right? Okay. Right, and so that was one group. They worked out 3 times a week, twice a week for 30 minutes for 8 months. And then there was another group that did like home-based, low-intensity exercises like walking, heel raises, sitting exercises, which is what we kind of define as the sit and get fit people, right? So what do you guys think happened after the 8 weeks? They looked at them, they did their bone, their DEXA scores, but they also looked at, if any of you people have been to physical therapy, you might have done a test called a timed up and go, or a 30-second sit to stand. They also looked at those functional outcomes, and this was the result. Not that, this. Okay, so if you look up here at the top one, the dark gray is the people that did those 4 exercises that I was telling you about. And the light gray group is the group that did the sit and get fit exercises. And as you can see, these were like the different lumbar spine, like the different areas that the SI joint that they looked at, their bone mineral density. And as you can see, the dark gray group got 3% improved bone mineral density than the light gray group over an 8-month period. Down here, what they were looking at are those tests I was telling you about, like the timed up and go, 30-second sit to stand, and you can see that the people that did the 4 exercises did way better than the light gray people. But the takeaway, the real takeaway home from this study is that nobody in this study that was in the 4 exercise group got injured. So you can lift heavy weights, you can improve your bone density scores and not get injured. And the second takeaway thing I think is super important is that these people did this study for 8 months, and the people that did the sit and fit, low intensity, home-based exercise got worse. They got worse. And 8 months is not a long time, So I think that's a good reason to get moving, start exercising, get on board. All right, so then kind of a theme, starting with Kate, is, so yes, having this diagnosis of osteoporosis or osteopenia, or saying someone telling you that you're prone to this disease, if you will, we have to take it seriously, we have to listen, we have to be cautious, but you need to find your Goldilocks, what's not too much, what's not too little, that's underdosing, because just like also Monica talked about, if you don't get the right levels of that K2, or, did I say that right? Okay. It's not going to help you. So you can be walking and you think or doing 5-pound dumbbells, and nothing's changing. So that Goldilocks level is super important. And if you don't know how to start, or you don't know where to go, or you're super scared, then that's what we're here for. We're here to guide you. Don't feel like you have to go at this alone. Don't feel like you're like, oh, I have to search Dr. Google, it's going to give me the answer. We're here for you, and we're here to help you. And, a exercise specialist who's trained in this type of exercise is somebody who should be able to help you. So, as I promised, if you are somebody, I don't know, Kate, if you want to help me out with this, a beginner person would, I was going to actually have everybody stand up, right? Everybody stand up. I don't want to block the slide, it's a good slide. So, just an example of like a heel drop. It's just like everybody go up on your toes, and then just drop your heels down. And like, I know this is like a slab floor, but like, I want to hear you people. You want to drop right? And you're gonna, it's hard because you're, I don't wanna say jarring, but you're loading your bone. So you want to feel some, pressure, stress going through your body. So that's just as simple as starting with that. And you don't wanna go say, oh, I have to do like, jumping jacks, or I have to jump on a 12-inch box to gain strength. You can start with like a takeoff, which the chart that I showed earlier, just like a spring works, right? So if we all not pretend, but we're gonna load our spring like we're gonna jump. So we're gonna bend our knees, and then we're gonna try to take off, but we're not gonna. Do you feel that stress pushing into the floor? Just that alone, go ahead, demonstrate again. Right, it looks like she's gonna take off.
I'm going, I'm working hard.
Right, and you're, right, so if we go back to, I just wanna put this slide back up. Whoops, there it is. Right, so that is the jumping takeoff. That is 3.5 times your body weight. Look what walking is. Walking is 1.2, right? Even like a heel drop. A heel drop is even more, what you guys just did. 3.6 times of what walking is, right? Okay, and then let's talk about the wrist. Do you want to show like a wall clap? Let's start with easy. Oops, I went too far. Oh no, I messed it up, Kate. I went too far.
Letting your body absorb the force. Don't just stay here. Land.
Right, or even like a clap, right? Like a clap.
And then
Right.
try to get some quickness.
Right. So I mean, and then you could I don't know if you want to go on your knees and show dropping, so dropping to the floor, right? So for those of you that probably looks like super, super scary. So I'm not going to say, oh guys, come to my class. Oh, you have a DATS score of whatever, a DEXA scan score of 2.5. Yeah, go do that. No, we're going to start with loading. We're going to see how you feel in 24, 48 hours of the next week. If you're good, we're going to load more. We're going to go progressive. We're going to go velocity driven. We're going to go right. Or maybe we're going to just start right. We're going to come to your level. And maybe we're not jumping, but we're doing sit-to-stands. But we're going to add a weight and start with a goblet squat because we're going to load our spine so we don't get those spinal or compression fractures, right? Marching, maybe we're going to start with marching, but then we're going to start, I hope I'm not going to break this floor, but we're going to start with, before we jump or do anything else, we're going to start with pounding and loading, making sure that our body can handle that. And then, as you guys can imagine, if anybody has any questions, we can talk about these advanced exercises, which you can imagine starting with jumping jacks, right? And then going to jumping jacks, right? So anyway, really, you want to see all of them? Well, a really important one is, here, is jumping with support. So if you're someone who doesn't feel like I can jump, you certainly can hold on to something, right? And just,
This is nice if a gym has a TRX, those straps, and you can help, and it'll help you land a little lighter.
But even with a TRX is something stable first,
Yeah.
and then progressing to, because those TRX straps, they're wobbly, where holding something solid, right? Is so even just trying just one. You don't have to go like this. You can just start one jump, take a break, another jump, take a break, or you can just start with those, what Kate was doing, right? With just the takeoff, right? Drop, push up from the knees is just, here, do you want to talk? Okay. Kate, just so you're on your knees and you're just dropping to your hands, burpees. Do you want to show the modified version? And then go to, okay, chair. So in my class, not that I'm doing a plug, but in my class, we start with the burpees, which is like this. So does everybody know what a burpee is?
No.
Okay.
I'll do the real
All right,
one.
ready? Remember, Jim, they were called squat thrusts For those of you who are like my demographic, squat thrust. Okay. Kate's too young. She'll remember that. Do the modified.
So modified would be like this. So I'm going to go down to the chair. I'm going to walk it back. I'm going to walk it back. And I'm going to come up. That's too easy. Maybe I'm going to do this. And then if I want, I'm going to add a jump. And then you can go from there. So that would be
A burpee. Crab walks. Here.
crab walks are, and I might not start with a crab walk. I just have my class just do this. Right? We're loading the wrists. It should feel like I need to shake my wrists out because I'm loading them. Yeah, you need to do that, right? And then walking. And then the reverse would be, this is a bear crawl. So we hold and we shake them out 10 seconds. And then we go, sometimes we go to like taps. And then we go to walking, which would, like an inchworm. Is that on there?
Yes, it's on there.
That one, you guys are going to make me sweat.
Lots of multi-purpose here, because it's not just loading on the upper extremity, on the upper body, but it's core, and we need that for the back, for the legs,
Right.
everything.
So farmers carries, how many people have to walk their groceries in from the car, and you got 10 pounds of groceries, or you're carrying your briefcase? That's a farmer's carry. So you're carrying weight. You got to go up the stairs just like from here. Some of them were snatching is what we call that. And some of them were just doing a full-on lift overhead. And then a goblet squat is basically when you're sitting to stand, you're standing, but I'm holding a weight, but I'm not doing it for my arms. The weight is adding load to my body, and I'm driving with my legs, like that. And that's what, and I don't know who makes these things up.
I know.
Andrea, how about a rebound? Does that work at all?
Oh, the question, that's a good question, but like a Pilates rebounder?
Or any?
Or do you mean like a tramp that you jog?
You're standing, there's gravity with you, that's good. There's quick movement, I like that. It's not about the heaviness of the load, but that's a fantastic exercise to help. I haven't seen any research studies specifically on those types, but it's a nice gentle way to work your joints. You're not landing on something hard, you're absorbing, it's good work.
I would say, again, it has a place. I would say you have to have this conversation with your doctor. You have to know your numbers. And just as we said earlier, if that's your mode, you've been using a rebounder, and you went in 6 months ago and got your DEXA scan, and it was the same, and then you got it 6 months later, and it didn't change, or a year later, it's not changing, then you need more than the rebounder. So, I mean, I don't know that you can actually say, right?
I don't have research to back it up, but if that's your way of moving, just keep moving, that's good. If that's all you've been doing for the past 10 years and your T-scores are low, that's probably not enough and it might need to be supplemented.
But I would say, don't.
Yeah, don't
It
not.
has a place. Yeah.
Wow, that was a lot. This is, I hope it doesn't feel like rambling, but I think we had a lot of joy just speaking to you. So if there's any other questions for any of us, don't go too far. Yes.
I was concerned that some of the people who were doing the exercises actually got worse. How could that be?
Because that magic threshold level, fracture and healthy, we know that there was osteoporosis, but their level was here, and then we pushed them to here, and we pushed them to here, and then we pushed them to here, and then their threshold changed, and then their threshold changed because they got stronger. So in that study, those women who had severe osteoporosis that lifted heavy weights, and not, when I say heavy, let's say you can lift 100 pounds, they made them lift 80 pounds, 80% of their maximum, 5 times for 5 sets. That's hard. I don't even lift that much when I want to. 80% of your maximum for 25 reps in one cycle twice a week of their, no, I'm saying if they're 100. None of them fractured. None of them. There was one muscle spasm. She missed one day. That was it. No, they got better. The ones that lifted heavy, the group that did what their standard, they just did, yeah, I'll do my sitting exercises and my band, and I'll go for walks. Pretty much, they needed a control group. People that didn't do nothing, but they didn't do this high intensity work. even though they thought they were doing something, they got worse. Their scores got worse. Did that answer? No. Now, okay, if I put you in a wheelchair and said never move, you get even worse. Does that make sense? It wasn't that the group, it just compared to the high lifting group, they didn't improve. They got a little bit worse.
Maybe you need, just as an example, maybe you need to do like that farmer's carry. Maybe you need to walk with weights.
Yeah, just the walking
It's not
wasn't
that
enough.
they're saying that the sit and get fit group, it just wasn't enough, and because they're characterized in this osteoporotic or osteopenia group, or in this case they had severe osteoporosis, it was like they weren't doing it, because it wasn't enough, so they were underdosed in their exercise program in those three principles I told you, progressive resisted, velocity driven, and impact. Was not enough impact to change their scores. So it was like they were being sedentary.
Yes.
And it was like their osteoporosis was progressing.
So let's do a couple more. If they're group related, I know we're going over. This is so much fun. If you have to leave, I get it. No, I'm not offended. If they're group questions, let's answer them. And if they're individual, you'll come and find us. Yes, go ahead.
There's some exercises that are better for the spine, some that work for the breast, some for the spine, some for the
So in general, yes, of course, it always depends. In general, to work the spine and gain more good stress for here, you have to add body weight. If you hold weight here, if you hold weight here, that would be good. Any kind of landing where you change your body weight impact, that's good for the spine because the spine is in the center. So I don't have to necessarily do spine exercises. I just have to do body exercises where my spine is working and in control. Would you agree? If I had to pick some, I would go more towards like the deadlift, the squats. Again, they're leg exercises, but the spine is holding extra weight there. I also prescribe Supermans where you're on your belly and you're lifting up. The part of the spine, nitty gritty, that we're concerned about with compression fractures is actually the front. You can't feel it. It's like way into there. Not these bony parts here. But when we do those Supermans, we're pulling on the back muscles to help pull on the back part, although it's usually the bending that pushes on the front of the spine is where we're concerned about.
There's lumbar spine, but
Yeah.
I thought the problem with osteoporosis is that the women end up being like this.
Oh, that's great. So yes, you see, and you saw that woman doing the overhead press, she already had a thoracic mid-back kyphosis, meaning some of those bones have wedged and changed that shape. Yes, and that's why I like to do those Supermans to help pull those bones up and pull them apart so it takes pressure off of the front part. And it's again this Goldilocks. I need to give pressure to make it better, but I want to take pressure off because I don't want a fracture, same thing. So we work it in both ways. So yes, but honestly, if this was your limiting factor and you had compression fractures in your thoracic spine, it's not going to stop your life. Lumbar will stop your life. You don't want to move. You're in the ER with pain. That's bad news. So I think we care more about these ones because it is holding up our entire body. Yeah. Yes. Oh, the second one, yeah.
For Monica,
Yes.
the yogurt, could you get a little more detailed about that, please, like you wrote down blank? Is it because of sugar?
Primarily, yes. If you can, I would recommend plain, but another great option as well is to add like your own sweetness, like a little bit of honey or maple syrup. Two reasons for that. One, you do want to limit the amount of added sugar that you're consuming in your diet, and yogurt is one of those sneaky places where it lives and it's marketed as healthy. The second reason is because we know that artificial sweeteners can actually really disrupt our gut microbiome, which sort of indirectly influences our bone mineral density. And so if you add a little bit of your own honey or maple syrup, you're being, A, it's not an artificial sweetener, and B, you're getting a much more controlled amount on there. And that's why I usually make that recommendation.
And what are the numbers for yogurt, for calcium and strengthening? Like
Gotcha.
The percentage, what are the numbers?
For how much yogurt, how much calcium is in yogurt?
Well, which yogurts and which, I know this isn't supposed to be a plug for companies, but.
Well, sometimes it's necessary, right? Because like I said, there are different brands, all different brands. So I actually found two things that I like to recommend. Cabot has a good amount of calcium. Like 5 ounces, I think, is like 335 milligrams of calcium, which is about 1 serving. Also, Chobani Complete. Now, that one's tricky because it does have an artificial sweetener in it. So I don't like to recommend that one as much, but depending on who I'm recommending it to, the Chobani Complete Kefirs, 25 grams of protein in there, also 330 milligrams of.
So the full fat.
So it's not necessarily about the fat content. The fat content does not influence the amount of calcium that's in there. More so the brand and the way that it's made will influence the amount of calcium in the yogurt. Yeah, you're welcome.
I feel like as you get older, like, one of my philosophies is I want to get as much nutrition out of every single thing I eat, because I'm eating less and less hungry. So I started looking at yogurt and kefirs have like several different kinds of probiotic bacteria, whereas the yogurt has just one. So I feel like the kefir is a better value for nutrition than the yogurt.
Yeah, kefir's a great way to get protein, fermented foods, so those healthy bacteria, and your calcium. I couldn't agree more. It's great, great option. Yes?
What do you think of taking collagen?
There's some research that shows, I believe it's about 6 grams of collagen every day can actually influence or improve bone mineral density when consumed with an overall healthy diet. So yeah, the research is there to support it. Again, just making sure that you're consuming that clinically significant dose, which is 6 grams, I believe, once a day. I could follow up, I'm not sure. I believe it was once a day.
Okay, thank you.
Yes?
When you mentioned olive oil, is it okay if you cook with the olive oil, or is that still something?
Good question. So generally speaking, the extra virgin olive oil, what makes it so anti-inflammatory is that antioxidant called oleocanthal. And oleocanthal cannot thrive in high heat. So if you're cooking with extra virgin olive oil in really, really high heat or baking in high heat, it will degrade that really good antioxidant that we want more of. So my general recommendation is have your extra virgin olive oil on your salad, sandwich, whatever that may be, or have it like under light sauteing. But if you're going to do more high heat options, I much more recommend like an avocado oil for your high heat foods. Yes?
My doctor doesn't want me to have any dairy because I've been having a lot of digestive problems. So I'm eating and drinking oat products and almond products, and most of them say they're fortified with calcium, but is that so? Is it okay, or how long can I do this?
Well, I have to be honest, I would challenge the response of decreasing dairy out of the diet. Is it, and this is a real, opens up a whole other can of worms, but often, and in some cases, in most cases, what aggravates us about the dairy is not the dairy entirely, it's the lactose in the dairy. And if that is your trigger, then I would absolutely encourage you to keep consuming dairy that just has the lactose in it. So for example, the milk I mentioned, like Bear Life milk or Lactate milk, or even some yogurts, are going to be just without the lactose, or give you an enzyme that can help break down that lactose. So that would be my first recommendation, and getting to sort of the root cause of that digestive problem, because we can't just keep restricting and restricting. By the time we're done, we're going to have no food left to eat. I mean, a diet of air. So, any other questions for any of us? Yes?
Is stevia in that artificial sweetener bucket?
No, great, thank you, I meant to clarify that, you're absolutely correct. So stevia and monk fruit are like natural artificial sweeteners, and there's actually evidence to support that they can actually be beneficial in our gut microbiome. When I think about the non-nutritive artificial sweeteners, I'm thinking about like aspartame, sucralose, I might even be forgetting one or two, but those are the ones that can actually be quite negative on our gut microbiome, yes. Yes, any other questions?